Bismillah ar-Rahman ar-Rahim. I am Dr. Mervat Abu Gabal, Professor of Internal Medicine and Rheumatology in Shams University. Welcome to the presentation of this undergraduate lecture in rheumatology. Our topic today is rheumatoid arthritis. I will share my screen now. As I said, our topic today is rheumatoid arthritis. First of all, what are our intended learning outcomes? By the end of this lecture, students should be able to define rheumatoid arthritis, know risk factors, pathogenesis, and clinical presentation of it, learn how to suspect and differentiate rheumatoid arthritis from other forms of inflammatory arthritis, understand how dangerous it is, this means what's its outcome, and finally, learn how to treat and follow up rheumatoid arthritis patient. First of all, what is rheumatoid arthritis? Rheumatoid arthritis is systemic autoimmune disease characterized by inflammatory arthritis and extra-articular involvement. Rheumatoid arthritis with symptom duration of less than 6 months or within first 6 months is defined as early rheumatoid arthritis. But when symptoms have been present for more than 6 months, it's defined as established rheumatoid arthritis. Incidence rate of rheumatoid arthritis are higher in North Europe and North America compared with South Europe. In North America and North Europe, rheumatoid arthritis affects 0.4 to 1% of population. On the other hand, in South Europe, it affects 0.3 to 0.7% of the population. There is higher prevalence of rheumatoid arthritis in female compared to male, with female to male ratio from about 3 to 1. And the prevalence of rheumatoid arthritis increases with age. Actually, rheumatoid arthritis can affect any age, with peak incidence between 4th and 6th decade of life. Regarding the etiopathogenesis of rheumatoid arthritis, actually it's not known. But like other autoimmune diseases, usually there is genetic susceptibility which interact with environmental factors, whether infectious or non-infectious, to produce the disease. Consequently, who gets rheumatoid arthritis? This means what are risk factors for development of rheumatoid arthritis. The most important risk factor is genetic susceptibility, as we will know. Also, epigenetics are important. Epigenetic mean alteration in DNA without change in sequelae of DNA, in amino acid sequelae of DNA. These alterations are heritable and produce change in cell function, but are reversible at the same time, like DNA methylation, histone acetylation. Gender or hormonal factor, especially estrogen, can stimulate immune system, so rheumatoid arthritis is more common in female compared to male. Environmental factors which constitute risk factors for development of rheumatoid arthritis include exposure to silica or asbestos dust, obesity and Western diet, vitamin D deficiency, and smoking. Actually, smoking is very important environmental factor that considered as great risk for development of rheumatoid arthritis. Infection, whether bacterial or viral infection like Epstein-Barr virus and other viruses, and change in microbiota at mucosal surfaces, especially at gut mucosa, oral mucosa, and lung mucosa, are important in as a risk factor in development of rheumatoid arthritis. Regarding rheumatoid arthritis heritability or genetics, the concordance rate in monozygotic twin is about from 15 to 30%, while in dizygotic twin it's about 5% only. The heritability of rheumatoid arthritis is approximately 40% to 65% for seropositive rheumatoid arthritis and 20% for seronegative rheumatoid arthritis. Actually, the risk of developing rheumatoid arthritis has been associated with human leukocyte antigen DRP1 allele. This HLA-DRP1 allele contain a stretch of conserved 5 amino acid sequence which known as shared epitope in the third hypervariable region of their DRP1 chain, which has been associated with risk of developing rheumatoid arthritis. Now, what about detailed pathogenesis of rheumatoid arthritis? Actually, the autoimmune changes that occur in rheumatoid arthritis are present already or are going on many years, even more than 10 years before development of clinically overt arthritis. At mucosal surfaces, especially at oral mucosa, lung mucosa, and gut mucosa, interaction between genetics, stressors, microbiota, and smoking result in induction of enzyme known as peptidyl arginine deaminase. This peptidyl arginine deaminase result in citrullation of peptides. Citrullation means conversion of arginine to citrulline inside these peptides. Now, what are these peptides? These are either intracellular peptides, which like histone, or extracellular peptides like fibrinogen, fibronectin, enolase, collagen type 2, or vimentin. These citrullinated peptides are now altered peptides. They start to bind major histocompatibility complex type 2 protein molecule or protein dimers, which are presented in antigen presenting cells, or which are present in antigen presenting cells, which are the dendritic cells and also macrophages. Now, macrophage and antigen presenting cells or dendritic cells are loaded with the autoantigen, which are the altered citrullinated peptides carried by major histocompatibility protein molecule and expressed on their surface. Now, while loaded, they migrate from mucosal site. They migrate to secondary lymphoid tissue, where antigen presenting cells present the altered citrullinated proteins or peptides to naive T lymphocytes, which recognize them and with co-stimulation by other cells start to secrete cytokines which stimulate B cells to produce autoantibodies against these citrullinated peptides. These autoantibodies are mainly ACPA or anti-citrullinated peptide antibody and rheumatoid factor, which is directed against FEC portion of altered IgG. Now, the patient has, during this period, autoreactive T cells and B cells, and these autoantibodies reach the circulation, but their presence together with cytokines and chemokines, which may precede appearance of clinical rheumatoid arthritis for years, is not enough to produce clinical synovitis. This need another hit, or this need triggering factor. This triggering factor is either infection, microbial insult, or maybe mechanical insult, or this may be immune complex formation and complement activation, which result cytokines and chemokines, which result in increased vascular permeability in the synovium and recruitment of neutrophils and chronic inflammatory cells to infiltrate the synovium, and also leakage of autoantibodies from circulation to the inside of the synovium. These result in activation of stromal cells in the synovium. The most important is fibroblast like synoviocytes. Now dendritic cells and macrophages activated inside the synovium start to secrete tubal necrosis factor, which is very important in activation of neutrophils, in production of angiogenesis, in increased production of metalloproteinases, and produce increased pain, together with other interleukins like interleukin 1, interleukin 6, interleukin 8, and chemokines, which increase chemotaxis and recruitment of chronic inflammatory cells from the blood to the inside to infiltrate the synovium. Also, activated T lymphocytes start to secrete rankle, which activate osteoclast precursor, result in proliferation, activation, differentiation to produce osteoclast, which start resorption of nearby cartilage matrix. Which start production of osteoporosis and bone resorption. Also, it secretes activated T lymphocytes, produce TNF, which is important pro-inflammatory cytokine, as I said, produce granulocyte, monocyte, colon stimulating factor, interleukin 2, interleukin 17, and interferon gamma. Now, activated B lymphocytes produce more auto antibodies like NCCP antibody and rheumatoid factor, which attack citrullinated peptide, altered IgG, and other autoantigen in the synovium, resulting in augmentation of this immunologic process and increase inflammation, hyperplasia, and hypertrophy of the synovium. The most important cell is fibroblast, like synoviocytes, which secrete, in addition to interleukin 6, they secrete prostaglandins and leukotrienes, increase vascular permeability and cause vasodilation, which help more leakage and more recruitment of autoantibodies and inflammatory cells from blood to infiltrate the synovium. They produce metalloproteinases, which result in degradation of articular cartilage and cartilage destruction. They produce rankle, which activate osteoclast precursor, which start bone resorption, produce bone erosion. The net result is occurrence of cartilage destruction and bone destruction and joint damage. At the same time, these fibroblast-like synoviocytes attain invasive or aggressive phenotype. They start to invade the surrounding structures, and even they migrate from joint to joint, which help progression of joint affection in rheumatoid arthritis. These events that occur at molecular level years before development of inflammatory arthritis, then with early rheumatoid arthritis, when arthritis become manifest clinically, are translated to pathology inside the joint. Compared to normal joint, the joint now show thick synovium due to hyperplasia and hypertrophy, with formation of aggressive granulation tissue, which is the pannus. These pannus contain activated chronic inflammatory cells, which are lymphocytes, macrophages, fibroblasts, plasma cells, dendritic cells. This aggressive granulation tissue, which is the pannus, erode adjacent cartilage and underlying bone, resulting in cartilage destruction and bone erosions, together with accumulation of inflammatory exudate inside the joint, which become swollen and hot. The inflammatory exudate or the synovial fluid analysis in case of rheumatoid arthritis show decreased protein, decreased glucose, and decreased complement. This inflammatory exudate is inflammatory in nature. This means it appears turbid, with increased total leukocytic count more than 2,000, with more than 75% of these leukocytes are polymorph nuclear leukocytes. Actually, As I said, interaction of risk factors, genetic and non-genetic risk factors, resulting occurrence of susceptibility to rheumatoid arthritis, then period of autoimmunity years before appearance of clinical rheumatoid arthritis known as preclinical phase, during which there is asymptomatic autoimmunity where cytokines, chemokines, and autoantibodies are present in the circulation, but the patient is usually completely asymptomatic with a normal synovial biopsy or near occurrence of clinical synovitis. There may be non-specific manifestation like arthralgia with minimal infiltration of the synovium by inflammatory cells, but with the onset of early rheumatoid arthritis in presence of triggering factor, early rheumatoid arthritis start by appearance of undifferentiated arthritis not fulfilling classification criteria for rheumatoid arthritis. By that time, the synovium show thickening, hyperplasia and hypertrophy infiltrated by chronic inflammatory cells, and the joint become swollen, hot, tender with limitation of movement. This is followed by established rheumatoid arthritis, which fulfill the classification criteria for rheumatoid arthritis. By that time, pannus is formed, starting to destroy the adjacent cartilage and bone and destroy the joint. All these manifestations or events that occur in rheumatoid arthritis at molecular level then translated to joint pathology and will be manifested as clinical manifestation. The clinical manifestation of rheumatoid arthritis include articular manifestation and and extra-articular manifestations. Articular manifestation are inflammatory arthritis. As I said, the affected joint become swollen, hot, tender, with morning stiffness more than half an hour, with limitation of movement. The main joints to be affected in rheumatoid arthritis usually is small joints, metacarbophalangeal and metatarsophalangeal joints, together with proximal interphalangeal joints of hands and feet. Later on, wrist, ankle, elbow, shoulder, knee, and hip joints are affected during disease course. The striking feature of rheumatoid inflammatory arthritis is the spare of distal interphalangeal joints and axial joints, except C1, C2 joint of the spine, which is affected characteristically in rheumatoid arthritis. Here are image and corresponding X-ray in early rheumatoid arthritis, where there is mild inflammation or inflammation of few proximal interphalangeal joints and few metacarbophalangeal joints, sparing distal interphalangeal. Here the X-ray is completely normal. There may be very mild non-specific periarticular osteopenia, but in established rheumatoid arthritis, more metacarbophalangeal joints or more joints are affected, and proximal interphalangeal joints wasting due to disuse, atrophy of small joints of small muscles of the hand is apparent here, and in the X-ray significant periarticular osteopenia appear, uniform joint space narrowing and erosion start to appear in established rheumatoid arthritis, but this is late stage here. In late rheumatoid arthritis, there is deformity like that deformity of the thumb with flexion at metacarbophalangeal and hyperextension at interphalangeal, swan neck deformity of little finger here with hyperextension of proximal interphalangeal and flexion of distal interphalangeal, together with subluxation and dislocation of metacarbophalangeal joints here. The corresponding X-ray will show presence of loss of joint space, ankylosis in some joint, subluxation and dislocation of other joint with loss of normal alignment, amalgamation of carpal bone, severe osteoporosis in bone, not only periarticular osteoporosis. As you will know, rheumatoid arthritis is very important risk factor for development of secondary osteoporosis. The corresponding C1, C2 joint here show a large pannus formation, aggressive granulation tissue, which compress the cord, resulting in cervical myelopathy. In long-standing severe arthritis, there is There may be mutilating arthritis here affecting both ankle and small joints and the rest of small joints of foot, together with appearance of extra articular manifestations in long-standing severe rheumatoid arthritis, especially in seropositive rheumatoid arthritis like subcutaneous nodules. These rheumatoid nodules appear over pressure area and juxta-articular. They characterize seropositive severe long-standing rheumatoid arthritis and are due to small vessel vasculitis together with presence of periangual infarcts and periangual erythema, which indicate small vessel vasculitis here in these patients. What about extra-articular manifestation of rheumatoid arthritis? As I said, usually occur in long-standing severe inflammatory arthritis or rheumatoid arthritis, usually in seropositive patients. Starting by ocular extra-articular manifestation, scleritis, episcleritis, and peripheral keratitis can occur. Rheumatoid arthritis is the commonest cause of secondary Sjogren syndrome with dry eye and dry mouth. Regarding lung affection, there may be lung nodules which may cavitate, produce pleural effusion. Also common, it's common to happen that there is interstitial pulmonary fibrosis in the lung, interstitial lung disease. Also, bronchiolitis obliterans with organizing pneumonia can occur and respond to steroid therapy in certain cases of rheumatoid arthritis. Regarding cardiac affection, the commonest cardiac affection as extra-articular manifestation of rheumatoid arthritis is occurrence of pericarditis, but also less common myocardial affection with myocardial fibrosis. Endocardial nodule with valvular lesion may occur. More common also accelerated atherosclerosis with ischemic heart disease and myocardial infarction can occur in patient as comorbidity, in patient with rheumatoid arthritis as comorbidity. Renal affection in rheumatoid arthritis usually iatrogenic, caused by drugs, especially non-steroidal anti-inflammatory or methotrexate, but in long-standing severe arthritis not responding to treatment with chronic inflammatory condition, amyloidosis can occur, which produce nephrotic syndrome. GIT affection is mainly iatrogenic in rheumatoid arthritis with mainly gastritis, even with occult blood in stool, but mesenteric vasculitis occur rarely in severe form of rheumatoid arthritis. There may be hematologic manifestations. The commonest is occurrence of anemia of chronic disease together with thrombocytosis and leukocytosis associating active rheumatoid arthritis, but in long-standing rheumatoid arthritis, especially with positive rheumatoid factor, leukopenia with splenomegaly can occur in Felty syndrome. Skin also can be affected as extra-articular manifestation of rheumatoid arthritis. The commonest lesion is occurrence of secondary renal phenomena, presence of skin ulceration, especially in the lower limb. Bioderma gangrenosa can occur also due to necrotizing vasculitis in cases of rheumatoid arthritis, in addition to skin nodules, which are characteristic to long-standing seropositive rheumatoid arthritis, and the underlying factor is small vessel vasculitis. There may be neurological manifestation as extra-articular manifestation of rheumatoid arthritis, especially peripheral neuropathy or mononeuritis multiplex in case of secondary vasculitis associating rheumatoid arthritis, or entrapment neuropathy, especially carpal tunnel syndrome or entrapment to ulnar nerve at the wrist, secondary to synovial hypertrophy and proliferation at active wrist synovites. These were most of the extra-articular manifestations that occur in rheumatoid arthritis. The commonest cause of mortality in rheumatoid arthritis is the cardiovascular disease, followed by respiratory disease. Then infection are important cause of this in rheumatoid arthritis. Also malignancy like lymphoma, lung cancer, non-melanoma skin cancer may complicate rheumatoid arthritis. Now, what is the clinical significance of extra-articular rheumatoid arthritis? Think to answer in face-to-face session. Now, rheumatoid arthritis is inflammatory chronic polyarticular arthritis. It should be differentiated from other forms of inflammatory arthritis. These are viral arthritis, including hepatitis C virus infection, connective tissue disease associating arthritis like in systemic lupus erythematosus, scleroderma, dermatomyositis or polymyositis, psoriatic arthritis, pseudo-rheumatoid presentation of calcium pyrophosphate deposition disease, peripheral spondyloarthritis, erosive osteoarthritis, even Lyme arthritis, and metabolic disease like chronic gouty arthritis. Now, how to differentiate? Think to answer in face-to-face session. After knowing what are pathogenetic factors and pathogenesis in brief of rheumatoid arthritis, the clinical manifestation of rheumatoid arthritis and differential diagnosis of rheumatoid arthritis, now how can we diagnose rheumatoid arthritis? Rheumatoid arthritis must be suspected in middle-aged female or even male suffering from inflammatory arthritis, but it's better to be diagnosed early in the disease course, where there is what is called window of opportunity. Introduction of DAMARD in this window or in this period in early rheumatoid arthritis can abort disease process and prevent joint damage. Diagnosis of rheumatoid arthritis is helped by ACR-ULAR 2010 classification criteria, which are restricted to individuals with at least one swollen joint, a score of 6 or more by use of this ACR-ULAR classification criteria is enough to define rheumatoid arthritis. This means we need a score of 6 or more. These classification criteria include variables. These variables are related to joint involvement, mainly joint swelling and tenderness, sparing distal interphalangeal, distal interphalangeal joints of hand and feet, excluding first metatarsophlangeal joints, and excluding first metacarpal joints, giving each joint affected score according to this criteria. Also, these variables include, or these classification criteria include symptom duration, include the serology, which mean rheumatoid factor and anti-CCP antibody positivity and its touch, and also acute phase reactant. Regarding rheumatoid factor is not specific for diagnosis of rheumatoid arthritis. At first, rheumatoid factor may be IgA, IgM, or IgG, but most commonly it is IgM directed against FEC portion of altered IgG. Rheumatoid factor is not specific for diagnosis of rheumatoid arthritis, but help in diagnosis if present in high titer in clinically suspected rheumatoid arthritis. Rheumatoid factor could be positive and present in other autoimmune diseases. It could be present in chronic infections, in other connective tissue diseases, so not specific for rheumatoid arthritis. Usually rheumatoid factor, when positive in significant titer in rheumatoid arthritis, it denotes severe erosive disease and usually accompanied by extra-articular manifestations. Regarding anti-citrullinated or cyclic citrullinated peptide antibodies, these are more specific for diagnosis of rheumatoid arthritis. It helps differentiation of rheumatoid arthritis from other form of inflammatory arthritis when present in significant titer. It is related to disease activity and also disease prognosis, and as I said, it is predictive of occurrence of rheumatoid arthritis, which can be detected in the circulation of patient years before development of clinically manifest rheumatoid arthritis. There are other autoantibodies like anti-mutated cyclic vimentin antibodies, which is type of anti-CCP antibody or ACPA. This autoantibody was known previously as hidden rheumatoid factor, which also may help diagnosis of rheumatoid arthritis if positive with high titer. Now, what about imaging in diagnosis of rheumatoid arthritis or imaging in assessment of patient with suspected to have rheumatoid arthritis? Usually conventional radiography is not helpful for early diagnosis of rheumatoid arthritis. Why? As you see, in early rheumatoid arthritis, the conventional X-ray appear just there may be mild periarticular osteopenia, which is not a specific or may be absent. There is normal articular surfaces and normal joint space. Later on, slight uniform narrowing of joint space occur, more prominent periarticular osteopenia occur, and late in established rheumatoid arthritis there is a narrow joint space, there is marginal erosion, or there are marginal erosions with significant periarticular osteopenia. Later on, deformities, subluxation, dislocation become apparent. So conventional radiography is not helpful in diagnosis of early rheumatoid arthritis. What about MRI? MRI help detection of soft tissue affection in early rheumatoid arthritis. It helps detection of synovial thickening and effusion in radiocarpal and midcarpal joints. Here, even it helps detection of bone marrow edema of carpal bone here, which is pre-erosive phase. But MRI is not always available, is not cheap, may be contraindicated or avoided in presence of claustrophobia, may be contraindicated in presence of metallic implant or pacemaker. So more easy and cheap is the musculoskeletal ultrasound. Actually, over the last decade, ultrasound has undergone a great evolution in field of inflammatory joint disease. Rheumatoid arthritis is probably the pathology that has most benefited from this development, both in terms of early diagnosis and monitoring disease activity. Ultrasound findings represent an additional advantage over clinical and laboratory evaluation, showing the phase of disease, whether proliferative synovitis or presence of erosion that cannot be detected by conventional radiography. As you see, this is a metacarpophalangeal joint which is completely normal. This is early synovial thickening, which appear as a hypoechoic lesion in metacarpophalangeal joint, together with interruption of bone cortex with appearance of very small starting erosion in head of metacarpal, which could be specific for rheumatoid arthritis if present in specific sites in early disease with inflammatory arthritis. Specific sites for erosion of rheumatoid arthritis are distal ulna, head of second and fifth metacarpal, and head of fifth metatarsal bone. Also, by use of power Doppler ultrasound, vascularity of the hypertrophied synovium appear, which indicate active synovitis, and progression of this synovitis and the size of erosion can be followed also by ultrasonography. Even more, ultrasound of the hand is sufficient to detect subclinical inflammation in rheumatoid arthritis in remission. Collectively, core set of sonographic abnormalities that can be detected by ultrasonography in rheumatoid arthritis. It can denote presence of synovitis, but not specific. It tells just there is inflammatory synovitis, and whether this inflammatory synovitis is active or not active. It can tell if there is bone erosion very early in disease process, especially when present in a specific site for rheumatoid arthritis. It can detect cartilage damage, can detect tenosynovitis, can detect tendon tear. Now, there are certain investigation should be done at baseline for patients with rheumatoid arthritis, especially after confirmation of diagnosis. This will judge our choice of therapeutic modality for this patient. Liver function test, especially liver enzymes, kidney function test, especially PAN and creatinine, urine analysis, baseline ECG should be done, baseline chest X-ray should be done for the patient. After diagnosis of rheumatoid arthritis and fulfilling baseline investigations for the patient, we must judge the level of disease activity in this patient and follow up this patient at first every 1 to 3 months with frequent evaluation of disease activity, especially when we will follow treat to target strategy in management of this patient, as you will see. There are several measures or parameters or indices that help assessment of disease activity in rheumatoid arthritis. These are the most famous or the most commonly utilized in clinical practice, like Simplified Disease Activity Index and Clinical Disease Activity Index. They are simple addition of certain parameters, certain simple summation of certain parameters. These parameters are number of swollen joint, number of tender joint, patient global assessment of disease activity on a scale from 0 to 10, evaluator or physician global assessment of disease activity on a scale from 0 to 10, and C-reactive protein only in Simplified Disease Activity Index but not present in a Clinical Disease Activity Index. There are cutoff values for different levels of disease activity, cutoff value for remission, cutoff value for low disease activity, moderate disease activity, and high disease activity. We can use and you can use as undergraduate these clinical indices to evaluate disease activity in rheumatoid arthritis in our clinical session and in your practice. Especially when you know that ACR-ULAR utilized the cutoff value of remission and low disease activity of SDI and CDI, they utilize these cutoff values to define remission and low disease activity in rheumatoid arthritis. So they are helpful. There is another disease activity index, which is DAS 28. This is disease activity score 28. It results from complex formula, also include number of tender joint, number of swollen joint, with use of global health assessment on a scale from 0 to 100, with use of either ESR or C-reactive protein. Also, there are cutoff values for disease remission by use of DAS, low, moderate, or high disease activity by use of DAS. These are the 28 joints utilized by CDI, SDI, or DAS 28 score. They must be examined to count number of swollen and number of tender joints. They include the proximal interphalangeal joints from 2 to 5 bilaterally, the metacarpophalangeal joints from 2 to 5 bilaterally, the interphalangeal joint and metacarpophalangeal joint of the thumb bilaterally, post wrist bilaterally, post elbow and shoulders bilaterally, and lastly post knee bilaterally. We will apply one of the simple clinical indices during our clinical round with our rheumatoid arthritis patients. Regarding Pauline remission criteria described by ACR and ULAR to judge remission of rheumatoid arthritis, despite it include simple parameters or few parameters, but it's not accurate. Guess why? Also, regarding ACR improvement criteria, which are ACR 20, ACR 50, ACR 70, despite including simple parameters also, but not used commonly in clinical practice, mostly due to the fact that it ignores the baseline activity of rheumatoid arthritis. In simple in simplified way, you can evaluate active rheumatoid arthritis by examining the patient and count number of swollen joint, count number of tender joint. You can evaluate patient global assessment on a scale from 0 to 10 regarding his disease activity. You can evaluate yourself the physician global assessment or evaluator global assessment on a scale from 0 to 10. Add to this evaluation of ESR with or without C-reactive protein. Don't forget to evaluate for CBC, presence of anemia of chronic disease, leukocytosis and lymphocytosis, which are associated with active arthritis in rheumatoid disease. This parameter should be evaluated at baseline and with each visit every 1 to 3 months while you are seeing the patient or following the patient. Now, what are ultrasonographic score in evaluating disease activity in rheumatoid arthritis? Many scores are developed to evaluate disease activity, like 7-joint score, 6-joint score. The best of them is 12-joint score. Even more, ultrasound signs of synovitis found to be predictive for flare and radiographic progression in patients with rheumatoid arthritis in clinical remission. And in a study on rheumatoid arthritis patients in sustained clinical remission, detection of power Doppler signal at joint level was found to be predictive of biologic Damard tapering failure and flare or relapse later on. Moreover, there is reported positive association between the presence of ultrasound detected bone erosions at rest, metacarbophalangeal and proximal interphalangeal joint level at baseline and the risk of relapse later on. Despite this, ACR and EULAR didn't incorporate or include one of these ultrasound scores that evaluate disease activity to either alone or in conjunction with clinical indices to evaluate for activity of rheumatoid arthritis. Guess why? Now, what will be your target in managing rheumatoid arthritis after diagnosis and evaluating the activity of disease? Using treat-to-target approach has been adopted by ACR EULAR and Asian Pacific League of Association for Rheumatology. Once rheumatoid arthritis diagnosed in a patient, the overall treatment target is to either reach full remission or at least low disease activity within a span of approximately 6 months in order to prevent joint damage, disability, and systemic manifestations of rheumatoid arthritis. Tight monitoring of disease activity is required, and change of or modulation of your therapeutic modalities should be performed if the target is not reached. By using this goal to reach disease remission or at least low disease activity, this can normalize physical function and prevent joint damage. If applied in early rheumatoid arthritis, also it can maximize physical function and prevent further joint damage if happen in established rheumatoid arthritis. Here is algorithm or diagram which clarify how treat-to-target approach is performed. After diagnosis of active rheumatoid arthritis, the Damard or disease-modifying drugs are applied. The patient is followed and assessed for disease activity every 1 to 3 months. If the target is reached with remission or low disease activity, well and good, assess disease activity and follow up the patient every 3 to 6 months to maintain this remission or maintain this low disease activity. If not achieved, modulate your therapy to reach the target. This decision of modulation of treatment should be shared with the patient considering comorbidities and other risk factors. Now, what is the importance of target approach in rheumatoid arthritis? Now, what are therapeutic options in rheumatoid arthritis. At first, non-pharmacological treatment include physiotherapy and also lifestyle modification like stop smoking, maintain regular exercise, maintain ideal body weight, and drug adherence. In advanced stage of disease, surgery may be required to correct ankylosing of the joint and deformity. There are two drugs which are anti-inflammatory. They are not disease-modifying drugs. One of them is not disease-modifying drug at all. This is the non-steroidal anti-inflammatory drugs. They are only they are only symptom-relieving drugs. They are used as arching drugs till the MARD produce their effects. They relieve pain and stiffness, but they don't affect disease progression. The other drugs are corticosteroids, which are strong anti-inflammatory. They produce non-specific immune suppression and rapid systemic disease-modifying effect, but this disease-modifying effect is minimal and they have long-term side effects, so cannot be used for long duration. The main drugs in treatment of rheumatoid arthritis which target inflammation and prevent further joint damage are disease-modifying anti-rheumatic drugs, which are DMARDs. These DMARDs are classified to synthetic DMARDs, include conventional synthetic DMARDs and targeted synthetic DMARDs, and biologic DMARDs, which include biologic originator DMARDs and biosimilar DMARDs. For you as undergraduate, it's enough for you to study the classification of these DMARDs and know few names of this under each topic. But it's important for you as undergraduate to study by heart the conventional synthetic DMARDs regarding their name, their mode of action, their doses, and their side effects. Now, what are common side effects of DMARDs? How can you monitor DMARD therapy? Seeing to answer in face-to-face session. After you know what are DMARDs and their classification, how can we use different therapeutic modalities in rheumatoid arthritis? We will use them according to 2019 updated EULAR rheumatoid arthritis management recommendations. These include 5 overarching principles and 12 recommendations. I want to highlight one of these principles. This is rheumatologists are the specialists who should primarily care for patients with rheumatoid arthritis. Please, despite the fact that rheumatoid arthritis for you as undergraduate is category A, you must know all about till drug doses, and these drugs, by these drugs I mean conventional synthetic DMARDs, but as GP it's better not to manage patient with rheumatoid arthritis. Just you must suspect this inflammatory arthritis is rheumatoid arthritis. You must confirm and diagnose rheumatoid arthritis. At least you may introduce the first DMARD, which is methotrexate, if no contraindication, to start managing of this patient, but please refer the patient to rheumatologist. He will treat this rheumatoid arthritis patient efficiently, individually, and safely. Regarding the 12 recommendations of management of rheumatoid arthritis introduced by EULAR, I want to highlight one or two of them. Therapy with DMARD should be introduced once rheumatoid arthritis diagnosis is made. Treatment should be aimed at reaching the target, which is low disease activity or remission. Remission at first, or at least low disease activity. The patient should be monitored early in the disease, every 1 to 3 months, with evaluation of disease activity later on every 6 months. Then, if the target is reached, methotrexate is an anchor drug. It's the main drug used as first treatment strategy. The rest of recommendation for application of DAMARD in management of rheumatoid arthritis will be revised, even applied in on our patient with rheumatoid arthritis during our clinical round. Here are some definitions. By poor prognostic factors in rheumatoid arthritis, we mean persistently moderate or high disease activity despite use of conventional synthetic DAMARDs, high acute phase reactants, C-reactive protein and ECR, high swollen joint count, presence of rheumatoid factor or ACPA, their positivity, or presence, if they are present at high presence of early erosions, failure of 2 or more conventional synthetic DAMARDs. All these are poor prognostic factors which direct our choice to therapeutic modality according to 2019 EULAR recommendations. Also, what is meant by low dose corticosteroids? This means a dose less than 7.5 milligram per day of prednisone or one of its equivalent. Now, regarding rheumatoid arthritis and pregnancy, if your patient is asking you, I have rheumatoid arthritis, can I marry? Can I get a baby? How can pregnancy affect mother and her fetus? Is there change in medications before, during, or after pregnancy? Seeing to answer the questions in face-to-face session. Regarding rheumatoid arthritis and pregnancy, the course of rheumatoid arthritis often change during pregnancy. Approximately 50% of pregnant women with rheumatoid arthritis have low disease activity, and 20 to 40% achieve remission by third trimester. However, nearly 20% will have worse or moderate to high disease activity during pregnancy. They may require further therapeutic interventions. Postpartum flare of rheumatoid arthritis usually occur, with the studies reporting rate ranging from 39 to 90%. This was as regards rheumatoid arthritis. Now, regarding juvenile idiopathic arthritis, it's just nice to know that juvenile idiopathic arthritis is one of most common chronic arthritis affecting children, with an estimated prevalence of 1 per 1,000 child. The term juvenile idiopathic arthritis defines heterogeneous collection of inflammatory arthritis of a known etiology with the onset prior to age of 16 years and minimum duration of 6 weeks, following exclusion of other causes of synovitis. The current International League of Association for Rheumatology, ELAR, classification criteria divide juvenile idiopathic arthritis into 7 categories, depending on the number of joints involved, presence or absence of extra-articular manifestations, presence or absence of additional markers including rheumatoid factor and HLA-P27. Here are the classification criteria for chronic arthritis in childhood. It includes 7 categories. These are systemic arthritis, which is a still disease, oligoarthritis with a persistent or extended, polyarthritis with rheumatoid factor negative, polyarthritis with rheumatoid factor positive, psoriatic arthritis, encephalitis-related arthritis, and undifferentiated arthritis. This is a 2019 ACR recommendation for management of juvenile idiopathic arthritis if you want to have a look. Now you can take home message. Rheumatoid arthritis is the most common inflammatory disabling joint disease worldwide. In addition to joint swelling and pain caused by inflammatory process, the ultimate hallmark of rheumatoid arthritis is joint destruction. Extra-articular involvement is another hallmark of rheumatoid arthritis, and this can range from rheumatoid nodules to life-threatening vasculitis. Current therapeutic strategies strive for early referral, early diagnosis, early start of effective therapy aimed at remission, or at least low disease activity with rapid adaptation of treatment if this target is not reached. Now, be ready with your questions till the next face-to-face session. Thank you for your time till we meet in face-to-face session. Thank you.